Yeah, thank you for inviting me to give this talk on design and analysis of cluster randomized trials. My name is Paul Milligan. I'm based in London at the School of Hygiene and Tropical Medicine. So some interventions can be delivered only at group level. We can think, for example, of a health promotion campaign that is delivered through local radio, or we can think of new clinical guidelines for hospital staff. These are interventions that can only be delivered and evaluated at group level. And the development of these methods for cluster randomized trials is relatively recent, and it really has opened up the possibility to evaluate a much wider range of interventions using randomized trials. And they're of particular interest to people who work on infectious diseases because they allow a method to assess the indirect effect of interventions on transmission. So this is the outline of the session this morning. We'll look at the reasons for using cluster randomization, and then I'll show three examples that I've been involved in malaria control. Then we'll talk about some of the statistical issues and the design, and then the analysis of cluster trials, and just very briefly some comments about ethical issues which are slightly different in cluster randomization. So what are the reasons for using cluster randomization? So some interventions are naturally delivered to groups rather than individually, or it may be more convenient or acceptable to do so. They allow us to capture indirect effects on transmission, which is of interest when evaluating interventions against infectious diseases particularly. And they're also useful because they capture real-life operational factors, and so you get more realistic estimates of efficacy, effectiveness and cost effectiveness from cluster randomized trials. And they're also used to reduce contamination. So for example, if one has an intervention, a health promotion intervention, people who are targeted with the messages could share those with people in the control group. And by doing the intervention in groups, then we can minimize that kind of contamination. So this is the first example. This is a study of seasonal malaria chemoprevention. So this is now starting to be used in West Africa. Several countries have started implementing this intervention, and children are given anti-malarial treatment once a month during the rainy season to prevent malaria. It was an important question about this was how it could be delivered, because there was really no delivery mechanism. And so this trial was done to compare two possible approaches. One was using lay health workers in villages who would go door to door to deliver the intervention, and the other approach was at the clinic, asking mothers to bring their children once a month to the clinic. So the intervention was monthly anti-malarial treatment to prevent malaria, and the outcome was the incidence of malaria cases in children that were diagnosed at the health centre. The unit of randomization was immunization outreach clinics, or the population that was served by each outreach clinic. And the design was a cluster randomized trial with two intervention groups. And there were 26 clusters, 13 in each group, and a total of about 12,000 children. And so these are the results. It's always important to look at the comparability of the groups at baseline, first of all. We can see here that they were fairly similar, the village delivery and the clinic-based delivery, similar number of children, slightly more in the village arm slept under a bed net, and slightly more were fully vaccinated. And then the main outcomes were the coverage of the intervention, which was much better in the village delivery arm. The malaria incidence was correspondingly lower in the village delivery arm. There was no difference in anemia, in the mean hemoglobin, which was also monitored. But there was a difference as well in the costs of the intervention, and the village delivery was considerably cheaper than the clinic-based delivery. So this a fairly large trial, the results boiled down to this table, which gave really very clear message that it was more effective to deliver this intervention through village health workers than at the clinic. So this is the second example, and this was a study of using mass drug administration in the Gambia, where malaria is very seasonal. The idea was to treat everyone in the population with antimalarial drugs in the dry season to try to remove the reservoir of infection, and then to monitor the effect of that on the incidence of malaria in children during the rainy season. And so villages were identified, and 18 villages were matched in pairs, and one village in each pair, everybody in the population was treated with antimalarial drugs in the dry season, and in the other village in the pair, they were given a placebo. And so here, this was a trial where the main interest was in the indirect effects of the intervention. And the third example that we'll look at is a phased introduction study. So again, this is seasonal malaria chemoprevention, and one of the questions that the policymakers wanted addressed was whether it would be really feasible to deliver this on a large scale, and whether it could be effectively delivered. And it was already clear that the drugs were beneficial at that stage, so it wouldn't have been appropriate to have a control group. But the intervention was phased in gradually, so this gives an opportunity to evaluate, because you can compare areas that have the intervention with areas that don't yet have the intervention, but in the end all the areas will receive the intervention. So this is a step wedge design, and 54 health posts were included, and the order that they introduced the intervention was randomized. So there are four key issues really that we need to consider. The first is the effect of clustering that has to be taken into account when calculating sample size and in the analysis of the results. Secondly, quite often in these trials, the number of clusters is relatively small, so we have to take care in the randomization to make sure that the groups are well balanced. Another feature of cluster trials is that it is quite common to randomize the clusters, and then after randomization to select the individuals within the clusters that you're going to evaluate. And so because of that, we need to take care that there isn't a selection bias. And then lastly, if we're interested in identifying whether there are indirect effects on transmission, then we need to evaluate the intervention in untreated individuals within treated clusters, and we'll look at an example of that later. So we'll look first at the statistical issue of using clustered data. So every group or cluster of individuals has its own characteristics, and it's important to take into account that individuals within a cluster tend to be more similar to each other than members of another cluster. And so this led the statistician Cornfield, who developed some of these methods, to make this statement that randomization by cluster accompanied by analysis appropriate to randomization by individual is an exercise in self-deception. And this was quite common in the earlier trials, that they were not analyzed correctly. And this will give confidence intervals that are too narrow and p-values that are too small. So we'll have over-optimistic assessment of the results. So why is that the case? So let's consider what happens in simple random sampling of individuals, where you have the whole population and you sample individuals at random, and cluster sampling, where we sample the cluster, and this is an example of sampling villages, and then in the selected villages you take everybody from that selected village. And these are quite different approaches and have different statistical properties. So this is showing a population that we wish to sample, and the blue line shows the expected results when we draw a random sample from this population using simple random sampling, and the mean will fall within a certain range of the true mean. When we use cluster sampling, the uncertainty is much greater, and the spread of the mean is much wider. So with cluster sampling, there's more uncertainty in our estimate because it's a less efficient method of sampling, and sample sizes must be increased to achieve the same precision, and they must be increased by this what's called the variance inflation factor, and that comes in because of sampling by cluster rather than by individual. So this variance inflation factor depends on two things. It depends on the degree of clustering and the size of the clusters. So the degree of clustering is measured by the intraclass correlation here, and the cluster size is B. So the larger the cluster, the larger the variance inflation factor. So for example, one of the endpoints in malaria trials quite often is the hemoglobin concentration, and we know from surveys that have been done that the intraclass correlation for this is about 0.04. So this is a measure of the degree of similarity within clusters of this outcome. So if we have a cluster size of 50, then we can calculate the variance inflation factor is nearly 3. So what that means is that if we use cluster randomization for this endpoint, we need a sample size that's 3 times as large as it would be needed in an individually randomized trial. So how do we, obviously in planning, then we need an estimate of the intraclass correlation, and we may find that from published studies. We may need to do our own pilot studies, and in our example we had a previous survey where we were able to estimate this, and we can use analysis of variance to calculate the variation within the cluster and the variation between the cluster means, and then the intraclass correlation is the variation between clusters as a proportion of the total variation. So it's a measure of how similar people are within clusters. And there are slightly different methods for binary outcomes and for incidence rates. And if you're going to need to use these methods, then this paper by Hayes and Bennett is a very useful reference that describes in a simple way the way to do the sample size calculations. So an important consideration is how we choose the clusters for the trials, and this may be determined by the nature of the intervention or the logistics of delivery, but we may also want to consider the need to minimize contamination. So we may minimize contamination by having larger clusters, but there's a penalty, as we've seen, for having larger clusters in terms of the overall sample size. The effective cluster size that matters, of course, is the number of people who will be sampled within the cluster, and that may be for some endpoints smaller than the total number in the cluster. So let's look at a few examples of this. So the first one here, this was a trial where they screened houses to prevent mosquitoes from entering. So the unit of randomization was the house, and the endpoint that was evaluated was anemia in children. They randomized 500 houses, and in each house the average number of children evaluated was just over 2. Of course, there's a possibility of contamination here because children could spend time in other houses, and that would be difficult to prevent. So one could consider randomizing a much larger unit, randomizing the whole village to one group or another group, but that would have resulted in a very much larger and more costly trial, so it wasn't felt to be feasible. Second example is the Mass Drug Administration trial that I mentioned earlier, and here there were 18 clusters, were small villages, a mean of about 200 children in each cluster, And the concern here was contamination due to infected mosquitoes or people coming into the clusters. And so to avoid that, there was a large buffer zone around the treated villages, and everybody in those areas were treated to try to reduce the effects of immigration of infection. And the third example is the step wedge evaluation of SMC effectiveness, where the introduction was phased in gradually. And there the size of the cluster was dictated by the health service that was organized, the delivery was organized through health posts, and so health post had to be the unit of randomization. So those are quite large. For some endpoints, these were evaluated by surveys, and so the number of children surveyed was much smaller than the total size of the cluster. So in most experiments, it's useful to use stratification because that can ensure that there's good balance between the groups for known important predictive factors, and also increases the homogeneity, which improves the power of the trial. An extreme form of stratification is pair matching, and at one time this was very common in cluster randomized trials, but there is a risk associated with it because it can be inefficient if the matching is not strongly associated with the trial outcome. And so nowadays stratified designs with a small number of strata are generally preferred. This is the data from the Mass Drug Administration trial, which was a pair match study. And you can see that the 18 villages formed 9 pairs, and this shows the incidence rate in each pair. So the way this is analyzed is that you calculate the rate ratio in each village pair. So we have 9 values there, and then the overall efficacy estimate is based on the geometric mean of those rate ratios. So there is a risk associated with this. It can be an effective method if the pair matching is very strongly related to the outcome, but there can be a loss of precision if that's not the case. So other steps that can be taken to improve the power and precision of the trial. So we've mentioned stratification, we've mentioned increasing the number of clusters. Constrained randomization is often used, and here you perform the randomization, you check that the groups are balanced, and you repeat the randomization until an acceptable degree of balance is achieved. And this is permitted provided that the number of possible acceptable randomizations is very large and that you choose from those randomly. And lastly, it's important to, if at all possible, measure the outcome before intervention as well as after intervention. And then this can be used to, in an adjusted analysis, to improve the power of the study. So I mentioned indirect effects, so we'll look at a little bit more detail how those are estimated. And a difficulty is that the magnitude of the indirect effects is very dependent on the local epidemiology. It will obviously depend on the efficacy of the intervention in reducing infectiousness. It will also depend on the coverage, the proportion of the population that received the intervention. It also depends on the basic reproduction number or the transmissibility of the infection in the particular population, and it depends on the transmission patterns as well. This shows the relationship between, on the left here, the basic reproduction number and the proportion of the population that have to be protected in order to eliminate transmission. And so it gives you an idea of the level of coverage of your intervention that you need to achieve to see a significant reduction in transmission. And for some of these vaccine preventable diseases, you can see that there are basic reproduction numbers ranging from 5 to 15. And that corresponds to 80 to 90% of the population that would have to be protected to eliminate transmission. So what is the basic reproduction number for diseases like malaria? Well, this has been estimated in this paper that appeared in PLOS Biology. And here they've plotted the basic reproduction number against the annual entomological inoculation rate. And you can see there's a huge variation, and the basic reproduction number can be enormously high in some places. And so in those settings, it would be very difficult to look at, to be able to demonstrate indirect effects, but we might be more effective in areas where the transmission potential is lower. So this shows the different comparisons that we can make when trying to estimate indirect effects. We can look at people in intervention clusters who did not receive the intervention and compare those with people in the control. So these are benefiting from the intervention in other people, but don't have the direct benefit from the intervention themselves. So this comparison lets us measure the indirect effects. We can compare people in intervention clusters who've had the intervention with control, and that gives us an estimate of the total effect, the direct plus the indirect effects. We can look at the direct effects by comparing between within intervention clusters, those that had and did not have the intervention. And lastly, we can look at the overall effect, which compares the incidence in the intervention and control clusters, and that will depend on the strength of the direct and indirect effects and also on the coverage. So these various different comparisons can be made. And so we'll give an example of where it's been possible to measure indirect effects. So this diagram has not appeared very well in the PowerPoints. This is showing the 54 health post areas in Senegal that were included in this study, and the intervention was phased in over 3 years, over 4 years. So in the first year, 9 health posts delivered the intervention, and then it went up a further 18 in the second year, an additional 18 in the third year. And in the intervention clusters, malaria chemoprevention was provided for all children under 10 years of age. And the outcome was the incidence of malaria, which was measured in all age groups. So it was measured in children, and that gives us an assessment of the direct effects plus the indirect effects. And it was measured in older age groups who did not receive the intervention, and comparing those in intervention and control clusters allowed us to measure if there were any evidence of indirect effects. And in this study, there was demographic surveillance going on that allowed us to estimate the size of the population that was at risk. So this is explaining how this kind of trial is analyzed. So the outcome is the incidence rate, which is the number of events divided by the time at risk. And the log of the incidence rate is assumed to follow a linear model. And so we have here the expected number of events, and that is related to a constant, the treatment effect. There's a term for the calendar year. There's a term for the total person years at risk in this cluster in this year. And then finally, there's a term for the cluster effect. And so this is fitted as what's called a random effect. So that allows for the variation from one cluster to another. So this is a Poisson regression model, and it's fitted to the observed data for each cluster, and it allows us to obtain estimates of the intervention effect. So you can do this in Stata, for example, and the command is xt Poisson. And then from the treatment effect that you get, you can calculate the percentage efficacy. So this was done for children and for older age groups, and these are the results. So the effectiveness against malaria in children that received the SMC was about 60%, and that compares with the estimates of efficacy that were obtained in the individually randomized trials that were done much earlier, where a higher efficacy was obtained, but in those studies they were carefully supervised and all children received the intervention. So this 60% efficacy is the kind of operational effectiveness in the real life setting. And then we saw, when we looked at the older age groups, that there was a significant reduction in incidence in those people who did not receive SMC, but were living in the clusters where children up to the age of 10 were receiving SMC, and so there was a 36% reduction in the incidence of malaria in those age groups. So that was an important finding, because it shows that not only can you protect the individual children with this intervention, but if you increase the age range, then you can start to have an impact on overall transmission. So in that example, we used a random effect model, so this is really the recommended approach for analysis if you have a fairly large trial, but they're recommended, these models, if the number of clusters is relatively large, perhaps about 20 or so per trial arm. Very often we have smaller studies, and there a simpler approach, which is an analysis based on cluster level summaries, is used. So we estimate the treatment effects from the cluster means and then compare these using a simple t-test, as we looked at in the example for the MDA trial. Other methods that can be used are listed here: generalized estimating equations or robust standard errors. So the point about the random effect model is it's a full probability model for the data, so this is really preferred. But these models are fitted iteratively, and you can have situations where it's difficult to fit them. And so in those cases, you can use the GEE model, which is it has the advantage that it allows for the different numbers of individuals within clusters. It weights those appropriately, but it's not a full probability model. And lastly, robust standard errors can always be calculated if both of those other approaches fail. So just lastly, very briefly, to touch on, because we're just about out of time, are ethical issues in cluster randomized trials. And so for the process of consent, there are two levels. There's consent to randomization, which is often given by community leaders or gatekeepers on behalf of the community. It may not just be feasible to obtain individual consent before randomization. If you imagine one of those trials that we've been looking at, if we had to get permission from every individual, it might be if we would need to get everybody to agree. What would we do if one household disagreed or didn't want to participate? So in general, in those kind of studies, consent is given on behalf of the community by community representatives, and then it's important to get individual consent for the intervention within each cluster after it's been randomized. And because this individual consent happens after randomization, of course, there's a possibility of selection bias, because your willingness to accept the intervention might be influenced by knowing which group you're going to be in. In some interventions, avoiding the intervention may be possible. We can think of a mass media campaign through local radio, for example, and so meaningful consent there can only really be given at the group level. So there's been much discussion about the ethical issues in cluster randomized trials, and this reference is a very useful one, the Ottawa Statement on Ethical Design and Conduct of Cluster Randomized Trials, that was published in PLOS Medicine. And so if you're thinking of getting involved in cluster randomized trials, this is a very useful source of information. So thank you very much. So I've just finished here with some references that you might want to follow up on to read more about some of these issues. There's a book by Hayes and Moulton, which is very comprehensive and also includes a lot of detail about planning and sample size calculation and methods of analysis. There's a paper in International Journal of Epidemiology by Bennett et al. That explains very clearly how to analyze different types of trial. And lastly, there's the CONSORT guidelines, which explain how you should report cluster randomized trials. And this is published in a number of medical journals, including the BMJ. So thank you very much.